As we already could see this in these previous sessions, we, including me, are quite easy going over to longer stems if we have to do a revision. And the question is it always necessary? I don't want to present you numbers, because I have no numbers, but a little bit of philosophical talk with some examples. In this case, 61-year-old lady, she has had metal on metal, and you can see the osteolysis around the proximal femur and the cup that is loose. So what did we do? We did a long stem, and we revised the cup. Just straightforward, no problem at all. And this is how it looks 2 years after. The question is, how does it look 10 years down the road? Will it be like that? That we have stress shielding like that with a loose stem, which gives much more problem than the previous prosthesis? Or will it look like that? You have almost very thin cortexes and almost no more bone around the stem. So, if you look at this prosthesis, even a longer one, look 1 month to 11 years. There's no bone left at all. What should we do and what can we do to prevent that? The problem is, as I already said, is stress shielding. When the stress to the bone goes through the metal implant, the bone is no more stressed and it disappears. So we have to stress the bone in order to keep it alive and active. Let's go to biomechanical testing. It's not important what kind of prostheses have been tested in this test, but it's interesting to understand what's going on in bone when you introduce an implant into the bone. This is a test setting. Here you have normal bone, and here you have a prosthesis. And the question is, how much with the prosthesis you lower the force introduction into the proximal femur or into the femur itself. So it has been done with 3 types of prosthesis. One very short, the Mayo stem, the Fitmore stem, and the CLS Potorno stem. But as I already said, it's not important what kind of prosthesis has been used. So the measurements taken have been at the level of the resotrochanter. Then, as you can see, 4 centimeters proximal to the tip and 2 centimeters distal the tip of each of these stems in 2 pairs of femurs. And what you can see in this busy slide, I will show it in detail, that you have a very important reduction. Minus means less force introduction into the proximal femur. So in a CLS, which is a very good, in my opinion, one of the best stems, non-cemented stems on the market, you see you have a reduction of stress force introduction into the proximal femur below the greater trochanter at the level of the lesser trochanter of almost 90%. And then you see here, still here you have a 30% in the mid-shaft, and just below the tip of the prosthesis you have a little bit more load introduction than in the normal femur. With the Mayo stem, you would think this is short stem. It's very similar. You have almost 80% reduction of force introduction into the proximal femur, and it continues down to below the tip of the prosthesis. It's a little bit reduced in a metaphyseal fixation shaft that is fixed here, but it's still 60% reduction of load introduction in the proximal femur. So when you use a stem, it can be another stem like this. It's also a short stem. It's the Optimis. Also 60% reduction of load introduction in the proximal femur, and it's about the same for this kind of copy of the CLS. So we have to admit, when we implant something into the bone, the load introduction produces a stress shielding. We have less load that is working on the bone. And the goal should be to reduce the stress shielding as much as possible. In some cases like this one, it's not possible to use something whatever shorter, thinner, or what else. You have to go through that area which is just paper thin, and you have to do something on the acetabular side. In this case, however, you have a prosthesis that is loose. It's not well fixed, the patient is painful, and he has a metal-on-metal prosthesis. We had to exchange it. So what you can do is to exchange it to a same size prosthesis. Don't go below the level of the prosthesis the patient already had. You can't see it anymore as you saw it before, and you will see it in the future. We always do, almost in all cases, we do a stepped trochanteric osteotomy for all the revisions, and this is keeping all the abductors completely alive, and they heal almost in all cases easily. And it gives you a lot of room to do your surgery on the acetabular side without harming the musculature, and it allows you, whatever you do, to go down to the femur. You can extend the osteotomy as far as you want to go. In this case, once again, you have the problem, this stem is relatively fixed, but you have the problem with this loose cage up here, metal back, and what we did in this case, we also went to a Spotorno CLS stem with the osteotomy that is 2 months after the surgery, and you see already callus formation at the osteotomy site, and the patient started to weight bear. Similar case here, you have the problem that you have a skirted head. This prosthesis was all the time dislocating. You see this cage up here, and you see here in the proximal femur, the prosthesis is not well fixed. The patient was painful. It's a very huge patient, more than 2 meters high and over 120 kilos. So what we did, this is the revision. This is not the revision. This is the revision. We used a normal cup, and we used a CLS stem in order to have a well-fixed stem again in the proximal femur. In this case, with a 55-year-old patient, and you see all those patients are quite young, so they have a life expectation of perhaps 20, 30 more years. So in this patient, she got, I don't know why, she got this head prosthesis after a fracture, and then she was very painful because this cemented stem was loose. So should you go to a longer stem because your bone is very thin? In this case too, we used a Spotorno stem, so a normal stem, and you see this is 4 months after the operation. You see that the bone starts to regenerate, and the stem seems to be stable. In this case, because the bone was so soft, we used, in addition to the screws, we used a wire in a figure of 8 to stabilize the trochanter. This is, once again, this is a straightforward case. You see this stem was probably too thin, and it was not well fixed. So what we did is, as you can see here in this view, the bone is swinging around the prosthesis in the proximal part. The patient was all the time painful. And what we did, we used even a short stem. It's much shorter, as you can see here, than the original stem. And it was integrated easily. This is the result after 1 year. So it's like a primary prosthesis. Another case, very similar. You have the swinging bone around here. It goes down to here. Here the prosthesis is well fixed, but the patient is painful. So what you can do, you could use, once again, a CLS, but you can also go to a shorter stem and have a load introduction that is much more proximal than it was before, and this is after 1 year. Another case, this very similar. You see the instability that produces incredible stress shielding and activity of the bone in this patient. The same, you can go to a shorter stem. And what's interesting is this is after 3 months, and this is after 1 year. And you see that the bone in the periphery starts to remodel, and I'm sure in 2 or 3 years it will look like a primary prosthesis in a normal bone. So I think more and more it's not necessary to go to longer stems. This is also unstable stem. If you have enough bony material, you can go to a short stem or a normal stem, replace it with a normal stem. Once again, after 1 year, this is a well-fixed stem, and you see again that the bone is adapting to the new situation. So this was my first case I did with a shorter stem, because this one was a patient very painful on this side from the beginning on, because she had a very, very narrow medullary canal, and this is the smallest size of prosthesis. So this prosthesis was just fixed here, and you see here up, the bone was swimming around the prosthesis, so this stem was never fixed. So you can replace it with a shorter stem, which gives you not so much the problem of the narrow medullary canal, otherwise you would have probably to ream it. And this is the result 6 years down the road. So in many cases, you could go with a shorter stem. So size really matters. And I think, keep in mind that shorter stem may introduce the load in the femur in a more physiological way than the long stems we are used to use. So go as short as possible. It's not necessary to go for a short stem, but at least, if possible, for a normal stem. But we should also force the industry to give us better material. Look at this prosthesis. This prosthesis is wider in the inferior part than in the proximal part. So the whole load introduction just happens in this area. If we would have something that is a little bit broader up here, we could replace it and fix the stem up here, and this is all this part of this prosthesis is not necessary. Thank you for your attention.